anterior 60. Lower full denture, lower denture, upper anterior, that is one English. Okay, this is a dangerous combination because it induces anterior chewing pattern. The anterior tooth are not able to withstand the occlusal forces. Okay, so there will be severe bone loss in the upper anteriors. So whenever there is anterior chewing pattern, it is bad for both the patient and the doctor because it will induce severe bone loss. So this bridge is moving and is causing pain. So that is the reason he is motivated to get the treatment. So for this patient, we have to start the upper first or lower first? Surgery.
Well, and
Yeah, it is
it
mobile.
will-
So keeping the upper, doing the lower is difficult. Usually we start the lower jaw first, but here it is better to do upper. So lower, if you see, the ridge is very much lower here, right molar, and very much lower in the left. Actually, the picture is not good. Take another picture which shows now bilateral severe resorption, and anteriorly the bone is somewhat picked out. Right? So we will understand how much alveoplasty we may need. First, we will start the lower plan. Okay, first we will see the reformatory. So we can see the mental foramen and nerve there, nearly on the top of the ridge. Okay. This is also very much closer to the wrist. There is nothing much to do alveoplasty. Already there is severe alveoplasty. We may do some mild flattening of bone here. Okay. This part. We may do some mild flattening and we may remove this irregularity. Not much bone to do alveoplasty, but better to open the flap. Because of the reason, because the bone is not even. Okay, the molar is in one level, the anterior is in one level, the canine area is in another level. There is one more bulge here. So we may not do a frank alveoplasty, but some mild leveling and reshaping. That's it. Okay. So it is a kind of severe resorbed category. So how to plan? So here you see this is a mental foramen. Okay. And this may be the mental foramen. So we will see the. So there are two options. One is place all the implants in the anterior and give cantilever. Or if possible, place implants in the molar also and avoid cantilever. If you are going for implants only in the interforamen area, giving cantilever, better to go for screw retained processes with titanium ring. Okay, we will see. First we will see the area in front of the right mental foramen. Okay. So this is exactly over the mental foramen. Actually the mental foramen is exiting over the crest. So definitely we cannot place implant lingually here. The space is very less. So we will come in front and even if you come in front and if you see the mental nerve loop is coming here. Okay. So that is why it is better to tilt it in front. Tilt it easy. is the mental foramen, almost in front, and we are tilting it mesially also to prevent injuring any. Um, the bone quality wise it is good, right? The width is good. Actually the bone quality is very much cortical in this part, lower half. So during drilling we should be more careful, during implant insertion we should be more careful, otherwise the implant will get struck or break. So it shows 14, but no need to use that much length, we can use a shorter one also. So we are planning for using a smaller diameter and 11.5 mm implant, 3.75 to 11.5 bioline MD. Okay. Then after that, you have to choose the 3132 area, right? Okay. So this is the midline. So just next to the midline we are choosing. This is another key implant. The bone quality is excellent. And the length is almost like 1.5 or 10 mm implant also is fine. And as usual the bone quality is very much dense. We have to drill sufficiently. No under drilling. Okay. And we are placing implant in the 3 to 3 1 region. Almost it is the same. Okay. 3.75 mm implant and 11.5 or 10 mm length. And now we are planning the lift mantle foramen area. This is the mantle foramen area, right? So this is mantle foramen area. We are starting the drilling in front of the mantle foramen and slightly tilt it easily. Okay. So better to open the flap and conveniently see the mantle foramen and do it. You will see the 360 degree view. Okay. We will verify the 3D reformer. Okay, it's almost close to the mantle foramen. We can push it slightly easily also. Okay. And we will try, is it possible to place one more implant in between the distal tilted and the anterior axis implant. It is possible to interfere. Okay. Almost in the canine area. Okay. So actually you can place 6 implant in the anterior. Inter implant distance is okay, otherwise it will show indirect. Okay, but still we need to do like this. What we can do is, one more technique is, what you can do is you can place one implant exactly in the midline. Okay, and place 2 implant. Now the inter-implant distance is much better. So this is kind of all on 5. Okay, so this is one option. The main drawback of this option is the cantilever is there. Okay. So almost in the, you have to give cantilever for second premolar and molar. Definitely, it is not possible to give second molar. So these are the drawbacks, and processes may break. This is unacceptable. So now we will analyze the distal mandible. Check any implant is possible. Immediately distal to mantle foramen will be placed. this. Okay. So immediately distal to mental nerve. This is the nerve. So the length available above the nerve is it's 2 mm. Okay. So it is not possible. So still more in the first molar area we are going. So this is the first molar cross section. So this is the nerve. The length available above the nerve is 3.8 mm. Even if you leave 2 mm for safety, only 1 mm bone is there, right? But if you look closely, buccally there is bone. Okay. Buccally, if you can place a thin diameter implant, like buccal bypass, you can place an implant. A short implant, 8 mm implant, you can place. Okay. So if you're planning for buccal bypass, go still more distal. The more distally it goes, the more the canal is closer to the lingual aspect. The more towards the premolar and mental foramen area, the more it is lingual. So this is the cross section almost in the second molar maybe. This is the canal. So you cannot do lingual cortical engagement here. These are the situations very difficult to do, almost not possible to do lingual cortical. Okay. Lingual cortical is not always we can do in all situations. In this kind of situation it is not possible. There is myloid ridge is not prominent, nothing is there. So only 4 mm height is there above the. So even if you leave 4.5, so even if you leave 1.5 mm for safety, only 3 mm bone is there, which is not enough. But you can place a short implant here. Especially if you use a very much tapering implant, there is for touching the nerve is less. So 3.75 into 8 mm implant will definitely work it. Okay. So we are finalizing this option. What we can do is, we can measure the distance from the mental foramen. So from the mental foramen, it is around 8 mm. So during surgery we can use this information. We use a scale or something to measure where to drill. Okay. What we can do is, we will go still more distal and check. This is more distal here, most of the distal root of second molar. Here it is much better actually, right? Here it is much better. Can we do lingual cortical here? It is not possible. Okay. Very thin bone lingually, you cannot bend it. Even if you bend it, it will crack. So this is a good case for, good situation for both bypass. Okay. Now we will check the left side. Okay. So this is a nerve, right? Just I kept the implant just above the nerve top. That means this is a nerve. This is one technique to find the nerve. Okay, if you see the cross section, we don't know whether this is a nerve or this is a nerve, this is a nerve. So what technique you can do is put the virtual implant directly over the radiolucency, not here or not here, and see the other window. You can see this. If you keep this implant here, the nerve disappears. Okay. Once you keep it directly above it, the canal is visible. This is one technique to find that. The height available is only 6 mm. Even if you go and touch the nerve, it is only 6 mm. Even if you keep 2 mm safety distance, it is only 4 mm, which is not possible. So we are going still more distally. Okay, it is almost in the first molar area. So we are going still more distally in the second, easy of second child molar. So here you can get some bone for getting buccal bypass. So this is the nerve. Okay. Keep on something to 8 mm, very short implant. We can place. Just keeping above the nerve, you will see the canal clearly. Okay. So what you have to do is open the flap, find the very lateralmost edge of the mandible, just leave 2 to 3 mm here and drill here, close to your buccal cortical plate. So that is the technique. So if you don't open the flap, the risk is you may start drilling here. You may end up during the nerve. So better to open the flap, open the lateralmost edge of the buccal cortical, then leave 2 mm and start the drilling. This is one technique. This is a better technique and safer technique. So if we can be able to place 2 implants in the second molar area, we are avoiding the cantilever. So first what you have to do is long incision from right to left. Open the flap, expose the metal foramen carefully without injuring it. Do a reshaping, leveling. Place the molar implant, and place the tilted implant and take care. X-ray. You have to confirm the safety of the westernmost implant. If they are good, if they are safe, what we can do is we can avoid these implants, these canine implants, and we can place only the middle implant. We can convert this into a all-on 5. If we couldn't able to place the distal mandible implant, what we can do is we will stick to the cantilever plan and we will place canine implant. Okay. Something like it also becomes a all-on 5, but with cantilever. If you put a distal mandible implant, it becomes a all-on 5, but without cantilever. Okay. So the main challenge is in elevating the flap, because long-term denture wear, the mediastinum will be very much adherent, and the mental foramen area you have to elevate the flap very much carefully. Okay. Here you may have to expose. You have to visually see this border. Then you have to drill. And one more challenge of this implant placement is the abutment will be very much buccal. Okay, that is one difficulty. So what we can tilt, you can do slight tilting the buccolingual. Okay. What you can do is you can do angle tilting the buccolingual. So the abutment will be in better position. The more you go distally, the more buccal it will come and it may impinge the cheek. The more mesially you come, the more closer it becomes to the canal. So these are the challenges. Somewhere we have to find the balance. So one is the midline. The midline implant is with a risk. Okay, this is a risk. You can see the beautiful two canals coming here. So what we can do is, so it is not exactly in the midline, it is just little to the midline. Okay. This we can. So if you see in the midline, there are two canals. You can see. We can see the two foramens here. Can you see here? This is the foramen through which it is entering. This is another foramen through which it is exiting. They form a blueprint. So that is why it is better to avoid midline implant. We will see. So that's it for the lower. Bleeding won't be any issue except in the midline if we elevating the flap, if we tear the foramen. It will be bleeding, but that it won't be that much. Something issue. Now we can